All right, let's walk through this case involving a 23-year-old male with an acute onset of shortness of breath and haemoptysis, guided by the images provided. First off, what we're looking at is a chest radiograph and axial CT images of the chest, which show some interesting findings. So starting with the chest radiograph, the most prominent feature here is the presence of multiple small nodular opacities in both lungs, but they're especially concentrated in the periphery of the left lung. Some of these nodules show cavitation, which is crucial. Despite the significant opacities, lung volumes are maintained, which helps rule out certain causes of lung disease where you'd expect reduced lung volume. There's also some pleural opacification at the base of the left lung, which suggests pleural fluid or even pleural thickening. Another key point to note is the presence of a well-positioned right-sided internal jugular line. No sign of pneumothorax here, so we're clear on that front. Moving on to the axial CT images, and this is where things really come into focus. These images show multiple cavitating nodules, predominantly in the peripheral parts of both lungs. This pattern of cavitation within nodules raises some red flags because cavitating lung nodules can indicate several serious conditions. There's also a variety of other opacities seen on the CT scan, including wedge-shaped pleurally based lesions that are highly suggestive of pulmonary infarcts, which ties in well with the clinical history of haemoptysis. Now let's talk about the differential diagnosis. Given the findings of cavitating nodules and peripheral-based infarct-like opacities, the primary differentials I'd consider are multiple pulmonary infarcts, especially considering the wedge-shaped opacities and the patient's age. If there's pulmonary artery dilatation or signs of emboli, it makes this even more likely. Septic pulmonary emboli. If this patient had a history of bacterial infection, we could consider emboli due to something like Staphylococcus aureus or Klebsiella. Wegener's granulomatosis, now called granulomatosis with polyangiitis, is another strong contender. This vasculitis can cause cavitating lung nodules, and in a younger patient like this, it fits quite well. Metastatic squamous cell carcinoma, not as likely in a young adult, but it's on the list. Rheumatoid nodules, possible but less likely considering this patient's presentation. So, given the findings, the diagnosis that fits best is Wegener's granulomatosis. The nodular cavitating lesions are typical of this systemic vasculitis, and the clinical symptoms of haemoptysis align with pulmonary involvement in Wegener's. It's also supported by the fact that pulmonary vasculitis can lead to hemorrhage and cavitation. Wegener's granulomatosis. A quick dive into this disease is warranted. This condition is a multisystem autoimmune disease of unknown origin. It causes necrotizing granulomatous inflammation of small to medium-sized vessels, which in turn leads to areas of necrosis and hemorrhage. The lungs are commonly affected, and patients often present with symptoms like cough, haemoptysis, and sometimes stridor due to airway involvement. Imaging in Wegener's typically shows a mixture of nodules, cavitating lesions, and areas of consolidation. These nodules can be quite large, up to 10 centimeters, and may coalesce over time. On CT, you might even see a halo of ground glass attenuation around the nodules, which indicates surrounding hemorrhage. A key diagnostic feature to look for is the CNK, cytoplasmic anti-neutrophil cytoplasmic antibodies, although it's worth noting that this test can sometimes be negative if the disease is confined to the lungs. If not treated promptly, Wegener's granulomatosis can cause renal failure, as it often affects the kidneys, causing glomerulonephritis in about 80% of cases. Without treatment, renal involvement can progress rapidly, leading to death within months. For this patient, management involves hospital admission and urgent referral to a respiratory specialist. Treatment would typically start with immunosuppressive agents like corticosteroids and cyclophosphamide to control the inflammation and prevent further damage. And there you have it. This case highlights the importance of linking clinical presentation to imaging findings, especially in multisystem diseases like Wegener's granulomatosis, where the lungs can show these classic cavitating nodules. Don't forget to subscribe to Radiology Made Easy for more breakdowns of cases like this, where we simplify complex radiological findings and walk through diagnoses step by step.